Okay, so this is my talk. This is the last talk for today. And I added a couple slides you'll see, but you'll get a new version of this. But I mentioned this before, but I thought I would share some slides. I think one of the challenges across all of imaging is in this post-COVID era, the limited staffing, the challenges of technologists, the fact we modified protocols. I mentioned about oral contrast before, and there was a shortage of IV contrast, general fatigue, overwork, and the like, kind of puts things into a challenge. That how do we do things well? And if you think about it, we all can miss things. Everybody misses things, but the most common reasons I find for missing things, are one of the most common really relates to poor scan protocols. The lack of oral contrast, the lack of IV contrast, or the timing, the wrong phases, are things that lead to error. And particularly in areas like the acute abdomen, which I'll speak about today, really is one of the areas where protocol really makes all the difference in the world. Now, in terms of oral contrast, there was an article written a few years ago by Alec Megabo making the point that you needed to use oral contrast in the ER setting. And yes, it slowed things down, but his comment was that the serious consequences of missed or incorrect diagnosis we always will choose what's best for the patient and not cutting corners. There was an article published about 2 months ago that I think is very important for all of us in the audience, and many of you probably haven't seen it, but this was an article that was published in JAMA Surgery, and it was written by a surgeon. And they looked to see the importance of IV contrast in looking at the patient getting CT in the ER setting for abdominal pain. And the conclusion was very simple, that if you did unenhanced CT, it was 30% less accurate than contrast-enhanced CT. So 30%. So if you ever get that argument from the ER docs why radiologists don't need IV contrast, this article is probably the strongest article I've seen, and it's not even written by a radiologist. So technique is everything. So I mentioned before in my first talk that we always give oral contrast. For a lot of the things, including the acute abdomen, we will use water. If I can't give IV contrast, then I will use positive contrast. I'll also use positive contrast if I'm worrying about a fistula, but for the most part, we're using water and then IV contrast at that 5 cc injection rate. And when I'm doing things like potentially ischemic bowel or a range of acute abdomen findings, I think it pays to do dual phase imaging because once anything related to the vasculature is in your differential diagnosis, the dual phase makes a big difference. If I'm just doing a routine abdomen, rule abdominal pain, rule out appendicitis, rule out anything kind of, perhaps, and particularly the patients are younger, I'm going to stick with the venous phase at about 70 or 80 seconds. But on these more complicated cases, I like to err on the side of doing dual phase imaging. And again, thin section CT, as we mentioned before. And as I'll show you from the cases, again, looking at axials only, as we all know, is not enough. And the role of multiplanar and 3D imaging, particularly MIP and then cinematic now, becomes very important. If I think about the small bowel in general, the classic things we always think about, wall thickening, changes in enhancement, be it increased or decreased enhancement, positioning of the bowel. Is the bowel malrotated? Is it in a hernia? What does the mesenteric fat look like? Are all things we think about and we look at basically on every case. Ischemic bowel, for an example, could be early on very bright bowel, but a few hours later, it could be decreased enhancement. So we need to look at many things to try to figure out, is there pathology present? And if there is, what specifically is the cause? We talk about bowel obstruction, and that's the first thing I'll address. We talk about a bowel loop over 2.5 centimeters. There's often something called the feces sign, which we'll explain a bit more in a second. We look at wall thickening, and we spend a lot of time in transition. I do think because I'm always looking at bowel transition, the coronal views are optimal for looking at bowel obstruction. And here's a simple example where you can see the dilated small bowel loops present here. And then as you go from the fluid-filled bowel loops, here's a loop which looks like it has stool, but it's small bowel. That's the feces sign. The feces sign kind of signifies a transition point. It's not always going to be there. Probably a third of the time it'll be there. But when you see it, it's very important. You can have feces sign in bowel, like patients with scleroderma or patients with motility states, but then all the bowels involved. When you start seeing segments of small bowel involved and you go from a dilated loop to this feces sign, you follow the transition to right here, and you know precisely that's the site of obstruction. And in this case, there's no mass present, there's no internal hernia, but that was a band. It was a patient who had an appendectomy 25 years earlier, and that was the band causing obstruction. And so this article recently spoke about the small bowel feces sign. Up to a third of cases, this feature is usually evident just proximal to the transition point and can help localize it. So I'm always very careful looking at what I would say is the fluid pattern of the bowel. Is it all fluid? Is there a transition? Very important to recognize that. Now in the ER setting, we also see lots of patients with Crohn's disease. CT has been used in Crohn's disease, MR is used in Crohn's disease. Sometimes we know the patient has Crohn's, often we don't. Crohn's is a very good example of inflammatory bowel disease because it gives you many of the key features, from mucosal hyperenhancement to wall thickening. I mentioned the wall should be under 3 millimeters. It's typically 7 to 10 millimeters with Crohn's. We see a stratification of the different bowel layers. We see prominent vasculature. One of the classic things is the comb sign, as I'll show you, and again, mesenteric involvement. Now, as I mentioned, sometimes we're using positive contrast. And here's just a good example of a patient without a history of Crohn's, but you can see the dilated loops of bowel, and then you see the multiple loops with the wall thickening. You can see long segments of bowel. Crohn's is, I think that jumped a little bit. Crohn's is very good at giving long segments of bowel involvement, very nicely shown here, and also shown on the coronal views. The comments we made before about looking at coronals is really ideal because when you're looking at axials, you're trying to build a vision in your mind. When you're looking at the coronals or the 3D, it's much easier to see everything a whole lot easier. And here's just another example here of Crohn's. And let me just push this in a little bit more because the images look a little bit off on telling the projectionist. Here's another example of Crohn's with this wall thickening. You can see it here on the coronal views, the extent of the bowel involvement, which is pretty impressive. And then instead of looking only at the coronals, I'll switch over to looking at the MIPS. You can see very nicely the vasa recta becomes very, very important. And the branching of the vasa recta is a very classic finding with inflammatory bowel disease. It's not specific for Crohn's, but it's very, very common in Crohn's disease. Here's another example. One of the things you see in Crohn's disease is fatty proliferation of the mesentery. You can see that involving large bowel or small bowel. You can see the mass effect here, right? There's no abscess here. This was the things that used to be called on plain films as a right lower quadrant abscess, but it's just fatty proliferation of the mesentery. When you look a little bit closer, you see this loop of terminal ileum. It's markedly thickened toward this ileocecal valve. And here's that fibrofatty proliferation, also well seen. And if you look at these images with MIP imaging, again, the prominent vasa recta is very nicely shown. Now, the question about the vasa recta, does that mean the patient has active disease? Not necessarily, but in my experience, when patients have very prominent vasa recta like this and thickened bowel, it typically is active disease. One of the things people also will call that is the comb sign. Again, very nicely here, you see the patient's SMA. You see the ileal branches off the SMA, the prominence to the terminal ileum, the mucosal enhancement of the terminal ileum, and again, very, very nicely shown in that example to give you a really good look at what is active Crohn's disease. Now, we typically think about Crohn's disease distally in the terminal ileum, but you also have to remember that Crohn's disease can occur proximally. This was a patient who actually presented what seemed to be gastric outlet obstruction, but you can see the duodenum, his third portion, his fourth portion, markedly dilated, but there's a stricture in between. And you might think about this as the patient ingested something, or perhaps there's a small carcinoma. It's only 1 to 2 centimeters. There's not much mass effect to it, but it's pretty impressive looking. This patient had endoscopy and biopsy, and this was Crohn's disease. So Crohn's disease can occur in the proximal bowel as well. So we typically don't think about it, but it's something important to think of. Now, when we look at the small bowel, and I'm trying to evaluate, I mentioned we look at the bowel, we look at the mesentery, and here's a good example where the mesentery really tells you a lot. This patient had an acute abdomen, clinical presentation, thought of diverticular disease, thought of appendicitis, and you start looking at the bowel, it's minimally dilated, but the main thing you see is this inflammatory process in the mesentery with multiple tiny air bubbles here. You can see it a bit better here where the thickening of the small bowel, and these are jejunal loops, but what about all these little dots of air? And here it is on the coronal view. And this is an uncommon etiology, but one of the causes of an acute abdomen, often leading to surgery, which is not necessary because patients can usually be managed with antibiotic therapy. And this is jejunal diverticulitis. So we always think about the colon for diverticular disease, but small bowel involvement does occur. It often has atypical presentations, and it's often goes under-recognized. You can see just another set of views here. It's a rare cause of inflammatory bowel disease. It's probably a bit more common in the ileum than the jejunum. When it occurs in the ileum, it really then simulates Meckel's diverticulitis, it simulates appendicitis, and it simulates Crohn's disease. So it's something good to think about. Again, it's not a very common entity. We see probably 1 or 2 cases a year, and a number of them end up going to surgery. As I mentioned, you typically don't need to. Here's another example here, inflammatory changes in the right lower quadrant, those multiple tiny air bubbles, which at first glance you say, well, the patient must have a perforation, but these are diverticuli in the small bowel, in this case the ileum, and you see the extensive inflammation present here and here as well. So it's a very important etiology. Again, it's a good example of where the inflammation in the mesentery is really the thing that you need to focus on. So mesenteric inflammation, Crohn's disease with the prominent vasa recta, the fibrofatty proliferation, and small bowel diverticulitis with lots of inflammation and multiple tiny air bubbles. Now, we all have an older population now, and in the acute abdomen, in the ER setting, one of the most common things we worry about is ischemic bowel. I mentioned at the beginning of the talk, in determining whether you're doing arterial or venous or both, I think older patients where ischemia is in the differential, you may want to err on the side of doing dual phase imaging. The radiation dose is not very high. The patients are a bit older. Ischemic bowel is a challenge. The earliest appearance of ischemic bowel is just some minimal dilatation of bowel. The most aggressive is portal venous air and mesenteric venous air. Unfortunately, when you diagnose it with mesenteric or portal venous air, there's a very high mortality rate, very high morbidity rate for those patients. So the earlier on you diagnose it, the better it is. Now, if I look back at mistakes that are made, I think one of the most common areas of mistakes is on ischemic bowel. And there are several areas that are typically problematic. One of the most common things is that people miss the presence of clot and vessel. Now, people will scroll the images, and maybe you'll notice in an older patient significant atherosclerotic plaque at the origin of celiac and SMA, but people are typically scrolling the images. Sagittal views, we've published this years ago, are most critical for being able to look at the patient's SMA and celiac axis, in this case an aneurysm as well. Now, sometimes it's a very easy diagnosis. You don't need those fancy views, right? Here's a patient, the axial images shows a pretty significant thrombus in the patient's SMA, which is shown nicely here as well on the sagittal view. And it's also shown nicely on the MIP imaging, where there's lack of flow for probably 4 or 5 centimeters. This is ischemic bowel. Patient needs to go to surgery. This is a very easy case, but I have to admit it's really not the typical cases I tend to see in practice. Here's another example. This patient comes in with abdominal pain. Nothing really specific on the clinical history side. If you look at these images, it kind of looks like a non-contrast study, but the patient did have IV contrast. And the bowel is just not enhancing enough. That's a bad sign. And if you look carefully at some of the jejunal loops, there's some air bubbles here, and maybe there's air in the bowel wall. You would have to be concerned. Maybe you're dealing with ischemia. When you look at the sagittal view, it's a great example because there's the celiac, which looks good. There's the SMA for about 4 centimeters. The SMA looks great, right? There's minimal plaque in the aorta. There's no plaque at the origin of the SMA. And this was read initially as negative because the person reading looked at the axial images. But you can see the patient has occlusion of the SMA. This patient went to surgery. Here's the patient a week later. They removed the clot. The patient did fine. There was no need for bowel resection, so this patient was very lucky. But you can see the ability to visualize that occlusion, yet the vessel proximally looks very, very good. Another example here. Again, look at the SMA. There's no plaque at the origin. The SMA looks like a widely patent vessel, but you get down about 4 or 5 centimeters, there's occlusion of the vessel. Long thrombus in the vessel. You can see the bowel loops here as well are beginning to look inflamed, irregular. The mesentery is inflamed. But again, look how easy it would be to miss this thrombus unless you were looking at the sagittal view. Now, I don't do legal cases, but I have to admit I've looked at a number of cases for MedChi of Maryland, and this is a typical example. This was one of the cases. This was a patient who came in with abdominal pain, and this study was read as negative. If you look very quickly, the upper abdomen, everything looks really good. And here's the SMA, and I'm only going to worry about the SMA. But the SMA looks great. But if you go a little further down, the SMA is not that great. But you have to admit, this is really far down. It's kind of hard to see, and maybe it's just partial averaging. But if the person would have looked at the sagittal views, they would have seen the SMA look great until it was occluded right there. So you have to really follow the SMA throughout its course. Yes, you can follow it down on axial imaging, but when it gets distal, there is that partial averaging. When you look at the sagittal, it's much easier to recognize that thrombosis, and this will lead to ischemia and to bowel infarction. We also need to look carefully on the venous side of things, which is why we talk about dual phase imaging. There looks like some stranding in and around the pancreatic head, and at first glance at these images, which are arterial phase, you may say, could this patient have pancreatitis? You scan down a little bit more, there's lots of induration in the mesentery, and you also notice this dilated loop of bowel with decreased enhancement, prominence of the vasa recta, and there's free fluid in the pelvis here. And you keep looking at these bowel loops. Look how thickened these bowel loops are. When you go back on the venous phase, there's thrombus in the portal vein, and there was thrombus extending from the portal vein into the SMV. So when you're looking at ischemia, you need to make certain you're able to recognize both the arterial and venous side of things. Here's that same patient with cinematic rendering. I kind of like this example because you see the edema in the bowel wall, which is something you can see very nicely. You can see the multiple layers of the bowel wall very nicely shown here. So again, a very important example. Now, another case. One of the things, Charlie White mentioned before about when you're doing an abdominal CT to look carefully at the pulmonary arteries through the lower lung fields. This was a patient with acute abdomen. And what you notice on the highest scan is there looks like either it's a clot or pseudoclot in the left atrial appendage, but this looks irregular. It looks like a true clot. As you scan further down, you then see what looks like clot, or infarcts rather, in the patient's kidneys. So you're looking at that carefully. You're also looking at the patient's vessels. Well, this is arterial phase. There's the SMA, looks great. There's the SMV, perhaps it's just simply too early. But look at the vessel here. The SMA there looks like it's occluded. And when you look at the reconstructed views, here's the SMA coronal. There's this dilated loop of bowel, which is really not enhancing. It looks basically like a loop of bowel with a volvulus with that twist appearance. And when you look more and more carefully at the patient's vessels, you can see very nicely the patient's thrombus in the patient's SMA and occlusion and ischemic bowel. When you look at the sagittal views in the patient, it's even more impressive. But again, look how nice the proximal SMA looks till it's occluded. And again, that's a very, very common area where people to miss things. Again, in the MIP imaging, you would really help yourself, right? Because here's hepatic, there's splenic, but there's the SMA, and the SMA just stops. And then you see distally some branch vessels, which means you have about a 5 centimeter length of occlusion. And here's some more looks at the small bowel axially and on the coronal views. So again, ischemic bowel and infarcted bowel in a patient who's developing a volvulus. So again, very important to recognize that. Now, the secondary findings, the finding in the left atrial appendage, the findings in the kidney, can all help you, make you look a little bit more carefully. Now, other things in terms of bowel ischemia or suspected bowel ischemia, I look at the vessel caliber. Like in this case, the vessels just look too small. When the SMA and celiac axis are really tiny like that, it's, even though the vessels are patent, it's impending ischemia. Now, when you go to the end of the spectrum here, the stomach's dilated. It looks like a little bit of free air in the abdomen. And here's the patient with significant pneumatosis. This is infarcted bowel, and survival at this point is just not going to happen. And you don't want to be diagnosing ischemic bowel when it looks like that. Okay. Now, other things in terms of acute abdomen, one of the things, and I'll cover, is the idea about complications. We do see more and more patients who are on different therapies, and often we think about the usual things with the acute abdomen of appendicitis, diverticulitis, ischemia, but you need to think about the history. Often we don't have a good history, but we're seeing more and more patients from the oncology side coming to the ER setting, and other patients with different medications. And again, the challenge might be we don't have the history, and even if we have a history, we're not certain if the findings we're seeing are related to the primary disease process, related to the therapy, or just related to a third or additional process. So here's a patient with abdominal pain, multiple thickened bowel loops. You can follow them down. Really impressive thickened distal small bowel. Here they are in the coronal views. So edematous, thickened angioedema, long lengths of small bowel, shown very nicely here as well. You can see it here on the targeted images. So now you're going through a possibility. Could this be ischemic bowel? What precisely is going on in this patient? But it's really long segments of bowel. You look at the mesenteric vessels, everything is patent. So what am I dealing with here? What kind of pathology involves the bowel to that extent? Well, we then found out the patient had multiple myeloma, and this extensive bowel was due to graft versus host disease. So we are seeing lots of patients who have graft versus host disease, not as bad as in the past. Patients usually do well now because of medications, but it's not uncommon for patients to get graft versus host disease and present with the acute abdomen. And it may not be something you think about because maybe you know the patient has myeloma, but you did not know the patient has graft versus host disease. And it's very important because you have extensive bowel wall involvement. It can involve esophagus, colon, stomach, but typically it's going to be small bowel. Another example, markedly thickened large bowel, markedly thickened multiple small bowel loops, really impressive enhancement, prominence of the vasa recta. Look at the edema. Look at the thickening on the cinematic rendering. Again, what gives you such extensive bowel involvement with vessels all being patent, so it's not an ischemic process? And again, this was another patient with graft versus host disease. And I think oncology patients are some of the most difficult patients. Again, small bowel pathology from obstruction to ischemia to various enteritis related to the patient's chemotherapy. And there's a few good articles recently published, again, thinking about how do we manage these patients. So here's a patient with a history of Whipple's disease for pancreatic cancer. This patient came in with right lower quadrant pain. Appendicitis was a thought. You see multiple loops of thickened bowel. You follow it downward. And look at the impressive distal small bowel here and here as well. So what is it? Enteritis? Is the patient have an effective enteritis? What precisely is going on? You can follow it on the coronal views as well. And in this case, the patient was on multiple different chemotherapy agents. Remember, patients with pancreatic cancer, all of them, even with negative margins, will be getting chemotherapy. There are some chemotherapies like 5-FU that are classic for giving bowel toxicity, but essentially any chemotherapy agent can do that, and most patients are on multiple chemotherapy agents. So if you're doing a patient, pancreatic cancer is a good example. Here's another patient with pancreatic cancer and abdominal pain. Again, a little bit, it looks like that graft versus host disease in the sense that it's very, very extensive. The vessels are all patent, but it's this submucosal edema, prominent mucosal enhancement, long segments of involvement, and prominent vasa recta. Again, what are we dealing with in a patient like this? This is a patient dealing with chemotherapy-induced enteritis. Now, most of these patients will do well. It's interesting, but a lot of the time we'll see very impressive CT findings, but the patient may not be symptomatic. So there's not necessarily a one-to-one relationship. And sometimes patients even have pneumatosis. We are worrying about infarcted bowel, but a number of different chemotherapy agents, particularly some of the newer agents, do give pneumatosis, even though there's no evidence of ischemic bowel. When we think about oncology patients also, the history becomes important. As I mentioned, who has had radiation therapy? Patients may have radiation and chemotherapy. Radiation enteritis is a bit easier to diagnose typically because it usually matches the patient's therapy port. It's most common in patients with like colon cancer. We have radiation to the right lower quadrant, or GYN tumors where there's radiation in the pelvis. Radiation colitis can be early in the disease process, or it can be late. Many patients with CT evidence of radiation enteritis are asymptomatic. Others are symptomatic. Here's just a good example. Again, the vasa recta becomes prominent. It's long segments of bowel, but it matches the patient's therapy port. So again, the history becomes very, very important. Now, just to be complete, it's not only going to be patients with oncology. Many of the medications patients are on, and ACE inhibitors is one that's the classic example, can get problems related to the therapy. Here's a patient who presents to the ER with abdominal pain. You see dilated loops of bowel. You see prominent vasa recta. You could be thinking about Crohn's disease. Patient has no history of Crohn's. Long segment involvement, marked edema, prominent vasa recta. What are we dealing with here? Well, when you finally spoke to the patient had been to her cardiologist and had high blood pressure, and a day earlier had started on high blood pressure medication. She was put on lisinopril, which is one of the common agents, one of the ACE inhibitors, but it gives you that enteritis secondary to ACE inhibitors. Here's another example, the same history. Very, very edematous bowel. You can go through a range of processes. This looks like the world's most aggressive ischemic bowel. It really doesn't look like ischemic bowel. It looks like some infectious etiology, pretty impressive involvement. Look at it on the coronal views, prominent vasa recta, ascites. Could the patient have ischemic bowel? Is this severe enteritis? You go through a range of possibilities in your mind, but look how extensive the bowel inflammation is. And this was another patient with diseased bowel with ACE inhibitors. Now, the question is, how do you treat them? Well, ACE inhibitors give you angioedema. It's not always the bowel involved. It could be the lips, the mouth. If you stop the ACE inhibitors for a day, literally you stop them for a day, you give the patients fluid, the patients will do fine. ACE inhibitors are a leading cause of drug-induced angioedema in the US. So again, the clinical history, the patient started medications literally 1 day ago, and you simply stop the medication and the patients do well. Many patients, because that's not considered, end up going to surgery because it looks like an acute abdomen and everybody is thinking about ischemia. So I've gone through a number of different things. Again, we always like to think about bowel and bowel pathology from small bowel obstruction. We think about ischemia. We think about diverticulitis. We think about a range of colitis, post-op patients. You think about pseudomembranous colitis. But there are many other things that we need to think about. Again, the importance of history cannot be overemphasized. Particularly oncology patients are becoming more of a challenge. Probably a number of you, like us, now have, in the oncology centers, they have their own ER departments. We still scan all the patients. They come to the regular ER, but 24/7, they're evaluating patients because with these newer chemotherapies, they're doing wonders at getting tumor response, but they also have increased complications. And I think it's important for us to be very much involved in the management. And with that, I thank you for attention, and I'll bring back John.